In the next section, we'll be talking about cardiac cell electrophysiology. In this section, we will discuss cardiac hemodynamics. Let's focus on the peripheral circulation. Oxygenated blood crosses the aortic valve into the aorta, and then that blood is distributed based on complex control mechanisms to different types of target organs. Oxygen crosses into target organs in the capillaries, and those capillaries feed veins which return to the heart. Which organs receive the oxygenated blood is very complex and is based on multiple factors. We will talk about those factors now. The cardiovascular system itself is composed as the heart as a pump and the distribution mechanism, which is the vasculature. The vasculature is composed of the arteries and the veins. And again, the exchange occurs in the capillaries and the microcirculations. Hemodynamics are the principles that govern where blood flows and when. The peripheral circulation consists of multiple types of blood vessels. This diagram shows blood vessels from the aorta all the way down to the venule, and it shows the components of those blood vessels as well as their diameter and wall thickness. You should remember that every blood vessel contains an endothelium. This is a one-cell thick layer that is responsible for multiple functions of the blood vessel as well as exchange. Elastic tissue is commonly seen in the aorta and other large arteries, as well as large veins and arterioles, as well as terminal arterioles. Smooth muscle is also seen in those blood vessels, as well as fibrous tissue. Capillaries are composed only of endothelium. Venules also contain some fibrous tissue but do not contain very much smooth muscle or elastic tissue. You should remember that a capillary has a diameter of 8 microns or 8 micrometers, which is approximately the size of a red blood cell. This is a graph that shows the mean pressure in the y-axis and the diameter of the blood vessel on the x-axis. What you see is that as the blood vessel size decreases, from the large arteries all the way down to the capillaries, you can see on this graph that the pressure drops as well. The pressure in the large arteries is between 100 to 120 millimeters of mercury. And then the resistance vessels occur. Those are the small arteries and the arterioles. The resistance vessels are the blood vessels that control blood pressure. The amount of relaxation or constriction of the small arteries and arterioles governs the peripheral vascular resistance. This is why we call them the resistance vessels. The capillaries themselves do not have smooth muscle and therefore cannot dictate systemic vascular resistance. The venules and veins, though they have a larger inside diameter, actually have a smaller mean pressure, as you can see from this graph. The venules have an inside diameter between 3 and 50 micrometers, and veins have an inside diameter of approximately 100 to 1,000 micrometers. This next graph, entitled Hemodynamics, shows the inverse relationship between velocity and area. In the aorta, you have a high pressure, a high systolic pressure, and a high diastolic pressure, and a low cross-sectional area. As the blood travels from the aorta to the arteries, to the arterioles, and the capillaries, the total cross-sectional area increases greatly. This is because you have much more capillaries in your body than you do large arteries, even though the diameter of those capillaries is much smaller than that of the aorta. As the cross-sectional area of the capillaries goes up, the blood pressure and the velocity both go down. It is velocity and area that have an inverse relationship, because as you can see, as the blood travels from the capillaries to the venules, the veins, and the vena cava to the right of the graph, the velocity begins to increase. The velocity can be seen here in blue. The blood pressure, however, stays low on the side of the venules and veins as well as the vena cava. It's important to remember that blood is stored in the venous system. The large to medium-sized veins can be thought of as capacitance vessels. This is a place for your body to store blood. Only approximately 15% of your total blood distribution is located in the arteries. The rest of the blood volume is either in the heart itself or in target organs. As we mentioned before, the flow rate of the cardiac system is constant because it is a system in series. The flow in the aorta is equal to the total flow in the capillaries, which is equal to the total flow in the vena cava. The cross-sectional area of those different compartments changes, however. This causes changes in total flow velocity. If you look on the left side of this cartoon, what you see is at point A, you have a velocity of 5 centimeters per second. You also at that point have a smaller area. As the area increases to 10 centimeters squared from 2 centimeters squared, the velocity drops from 5 centimeters per second to 1 centimeter per second. This is important because in the capillary, you have a higher total cross-sectional area. This causes a lower flow velocity. This lower flow velocity allows time for oxygen and nutrients to travel out of the blood and go into the tissues. This is represented by point B. Point C represents veins and venules. At that point, the blood is deoxygenated and is traveling back to the heart in a relatively fast manner at 10 centimeters per second. The flow is equal from point A to point B, but the velocity changes as the area increases. Flow depends on the pressure gradient and the vascular resistance. So Q, which equals flow, is equal to the change in pressure divided by the resistance. This is also known as Ohm's law, V equals IR, or I equals V divided by R. The change in pressure is equal to the mean arterial pressure, or the mean blood pressure, minus the right atrial pressure. This is the pressure drop, or the voltage, between the arteries and the veins. Remember that the right atrial pressure is equal to the jugular venous pressure, which is approximately the pressure in the superior vena cava. Peripheral vascular resistance can be measured by blood velocity and the radius of the compartments, which is also known as Poiseuille's law. But peripheral vascular resistance practically is actually derived from the following equation. Mean arterial pressure is equal to cardiac output times the vascular resistance. When doing a cardiac catheterization, we can calculate the total peripheral resistance, also known as systemic vascular resistance, by a modification of Ohm's law, which is equal to mean arterial pressure equals cardiac output times the total peripheral resistance. We can calculate the peripheral resistance by taking the mean arterial pressure and dividing by the cardiac output. The right atrial pressure is usually around 0 to 5 millimeters of mercury and is therefore excluded from this equation. Again, Poiseuille's equation, which is resistance is equal to 8 times the viscosity of blood times the length of the blood vessel divided by pi times the radius of the blood vessel to the 4th power, is not something we commonly use clinically. However, this is an important equation for the boards because what you should know is that as the radius of the blood vessel changes, for example, if the radius changes by 1/2, the resistance will go up 16-fold, or 2 to the 4th power. It's important to remember this because many times on the boards you will see this question asked. Another number that you should be familiar with is Reynolds number, or N sub R. This number is important in determining laminar versus turbulent flow. Laminar flow occurs when blood flow is even throughout a blood vessel. Turbulent flow occurs when blood moves in an erratic fashion, irregularly through a blood vessel. The body prefers laminar blood flow. There are multiple disease states associated with turbulent blood flow through blood vessels. You can calculate the Reynolds number through the following equation. N sub r is equal to density of the blood times the diameter of the blood vessel times the velocity of the blood flow divided by the viscosity of the blood. When a critical Reynolds number is exceeded, Re, turbulence will occur. Again, as cross-sectional area increases when you move from the aorta to the capillaries, the velocity of the blood decreases. This inverse relationship is seen in all blood vessels. Blood flow will develop a velocity profile within a blood vessel. Again, laminar flow is streamlined, all of the elements moving in a parabolic profile. Increasing the velocity of the blood leads to more irregular flow and an increasing likelihood of turbulent blood flow. Turbulent blood flow involves mixing of blood with inefficient flow and increased resistance. Why is turbulent blood flow important? Turbulent blood flow is the cause of murmurs and bruits. Also, turbulent blood flow is associated with atherosclerosis and hemolysis. This diagram shows the difference between laminar blood flow and turbulent blood flow. Turbulent blood flow is more likely to occur in blood vessels with atherosclerosis. Also, turbulent blood flow has been shown to cause atherosclerosis and vessel damage through increased shear stress at the level of the endothelium. The compliance of a blood vessel measures its distensibility. Compliance can be calculated by the change in volume divided by the change in pressure. As a person becomes older, the blood vessels will stiffen because of increased calcium and fibrous tissue deposition. An older person's blood vessels will have a decreased compliance. And as blood vessels have a decreased compliance, they will develop a higher pressure. The heart will then require additional force to overcome this afterload. In this chart, you can see different aged patients and changes in their pressure in that blood vessel over a change in volume. The person who is 20 years old at the bottom in blue has a very small change in blood pressure as the change in volume increases to the right, as compared to the 75-year-old person who, with a very small change in volume on the x-axis, has a very high change in pressure on the y-axis. The arterial system is responsible for carrying blood with oxygen from the heart to the peripheral organs. The systolic pressure is the maximum pressure, the diastolic pressure is the minimum pressure. The difference between these two pressures is the pulse pressure. Pulse pressure is equal to the systolic pressure minus the diastolic pressure. The mean arterial pressure is calculated by the systolic pressure plus 2 times the diastolic pressure. This entire term is divided by 3. The pulse pressure can be increased by age, stroke volume, as well as vessel compliance. Patients who are elderly often have very high pulse pressures with increased systolic pressure but normal diastolic pressure. This is caused by calcification of the large arteries. Here you see a diagram of pulse pressure with the systolic pressure on the top and the diastolic pressure on the bottom. Pulse pressures are increased by age, stroke volume increasing, decreased vessel compliance, and aortic valve insufficiency, or aortic regurg. Pulse pressure is decreased by an elevated heart rate, increased resistance, and aortic valve stenosis. The venous system is responsible for returning deoxygenated blood to the heart, as you know, and also removes waste products from peripheral organs. Veins in general are highly compliant. The changes in the vessel diameter are what the determining factors are for venous return. The systemic nervous system is the primary controller of venous tone. The muscle pump is what's thought to be the major contributor to the return of venous blood to the heart. Veins, as you know, contain valves, and these valves prevent backflow of blood from the heart into the leg. Muscle contraction pumps venous blood from the leg up to the heart. The microcirculation is consisting of the arterioles as well as capillaries and venules. The capillaries are the smallest blood vessels. Again, they are a single cell layer thick, and that cell is an endothelial cell. Capillaries do not change their diameter, and they also do not control blood flow. It's important to remember that not all capillaries are perfused at all times, especially in tissues such as the skin. Precapillary vessels are small arteries and arterioles. These precapillary vessels are what are responsible for regulating the peripheral vascular resistance, also known as the systemic vascular resistance. These vessels also regulate the local blood flow. The terminal arterioles are responsible for regulating blood distribution. Again, capillaries are a single cell layer thick, and capillaries can be continuous or discontinuous, meaning some capillary systems have large fenestrations or windows that allow red blood cells to exit the capillaries, such as in the spleen or the liver. Other capillaries are continuous, meaning they only allow nutrients to travel from the bloodstream into the organ. Postcapillary vessels, such as small venules, are responsible for influencing hydrostatic pressure. These vessels are also known as capacitance vessels because they are able to store large amounts of blood. There are many control mechanisms that regulate the microcirculation. These include neural factors, such as the sympathetic nervous system. The sympathetic nervous system is maximal at the small arteries and arterioles and is responsible for regulating the systemic blood pressure. Humoral control mechanisms are also able to control the vessel diameter and capillary permeability by circulating factors such as hormones. Metabolic control mechanisms, such as adenosine, are byproducts of metabolism and can cause vessel dilation, especially in coronary arteries. Myogenic control mechanisms rely on increased pressure around the capillary, which causes vessel constriction. Decreased myogenic control mechanisms around a blood vessel can cause dilation. The endothelium is also very important for causing changes to the microcirculation, especially with regard to nitric oxide. The endothelium is responsible for the release of nitric oxide through nitric oxide synthase, an enzyme. This often occurs in response to parasympathetic stimulation. This causes vasodilation. At the level of the capillary, exchange occurs. Fluid is able to move between the capillary and the target organ. The movement of fluid between the capillary and the target organ is governed by the hydrostatic pressure, which means the blood pressure or the fluid pressure, as well as the osmotic or oncotic pressures. The Starling equation, which is pictured here, is Q, which is net flow of fluid across the capillary wall. A positive Q means flow of fluid out of the capillary into the tissue. A negative Q means flow of fluid from the target organ back into the capillary. K is the capillary filtration coefficient, which is a standard number that you will be given on the test. You won't be asked to memorize what that number is because it differs from organ to organ. The capillary hydrostatic pressure is the blood pressure in the capillary. The interstitial fluid hydrostatic pressure is the amount of fluid in the target organ and the pressure that it exerts on the surrounding tissue. Pi c is the capillary oncotic pressure. This is a measure of the amount of protein in the capillary. The interstitial fluid oncotic pressure, or pi I, is the amount of protein in the interstitial fluid in the target organ. The factors favoring filtration are capillary hydrostatic pressure and tissue oncotic pressure. Filtration means positive Q, or the movement of fluid out of the capillary into the target organ. Factors favoring absorption are a negative Q, which means the movement of fluid from the target organ back into the capillary, are capillary oncotic pressure and interstitial hydrostatic pressure. Normally, capillary oncotic pressure is constant at 25 millimeters of mercury due to a constant level of albumin in most healthy patients. The capillary hydrostatic pressure is usually approximately 32 millimeters of mercury at the arteriolar end and 15 millimeters of mercury at the venous end. The interstitial hydrostatic pressure is usually around 2 millimeters of mercury, and the interstitial oncotic pressure is usually low, around 5 millimeters of mercury. At the beginning of the capillary, which you can see here on the left side of the diagram, filtration is favored. Fluids move out of the capillary into the target organ. At the distal portion of the capillary, which is the right side of the drawing, absorption is favored as the fluid re-enters the capillary. It is important to realize that this allows for recycling of fluid out of the capillary and back in. This causes the absorption of wastes from the tissue and the delivery of nutrients to the tissue. Lymphatic vessels are responsible for the return of excess interstitial fluid and plasma proteins back to the bloodstream. Lymphatics have a very high capacity to be increased by approximately 20-fold over their baseline. When lymphatics are overwhelmed or obstructed, patients may form edema. Because there's a high likelihood of you seeing this question on the boards, we'll go over it again. What is the Starling equation? The Starling equation is J, also seen as Q sometimes, which is flow, or net fluid movement through the capillaries, times the capillary filtration coefficient, multiplied by pressure in the capillary minus pressure in the interstitium minus sigma, which is a reflection coefficient. Usually this is between 0 and 1. For most cases it's 1, times pi c minus pi I. The skeletal muscle circulation is an important special circulation that we'll talk about. Skeletal muscle is about 50% of the body mass, but at rest only receives about 15% of the cardiac output. At resting time, only 1/3 of the capillaries in the skeletal muscle are actually perfused. This is due to a high resting sympathetic tone. With exercise, however, an increased sympathetic tone above the baseline, the perfusion to the skeletal muscle can increase to approximately 80% of the cardiac output. The cutaneous circulation is another important special circulation to remember. The function of the cutaneous circulation is not only to deliver oxygen and nutrients to the skin cells, but also to regulate the person's body temperature. The subpapillary venous plexus, which is a low-velocity blood system, promotes heat dissipation when those blood vessels are open. Arteriovenous anastomoses, or openings, are channels by which blood is able to get from the artery to the vein without using capillaries. The cutaneous circulation has multiple anastomoses, which allow for shunting of blood directly from the artery to the vein. The flow of blood between these anastomoses is regulated by the sympathetic nervous system. The apical skin, which is seen in the hands, the feet, the face, and the ears, contains a high number of AV anastomoses. These channels are very important for thermoregulation. In response to cold stimuli, initially there is vasoconstriction. This allows blood to not enter these AV anastomoses. This conserves the patient's warmth by keeping the blood below the level of the skin. At very cold temperatures, however, vasodilation may occur to allow the skin to warm up again in order to prevent frostbite. This occurs through AV anastomoses. As we've talked about before, the coronary circulation involves the arterial supply of blood and nutrients to the heart through the right and left coronary arteries. The venous return from the coronary arteries is via the coronary sinus and the anterior coronary veins. The coronary sinus drains directly into the right atrium, and the anterior coronary veins can drain into either the left ventricle or the right ventricle, directly into the chamber of the heart. The coronary circulation generally represents 5% of the cardiac output, but the flow depends on the cardiac cycle. Remember that during systole there is increased flow resistance in the left ventricle. During diastole, there is maximum flow in the left coronary artery, especially during isovolumic relaxation. In the right ventricle, remember that the pressure does not depend on diastole for coronary perfusion. This diagram again shows that during diastole, after the second dotted line, there's increased perfusion in the left coronary artery. In the right coronary artery, however, there is no dependence on the cardiac cycle for coronary blood flow. The control of the coronary circulation is primarily metabolic, meaning that as a person exercises, their metabolism increases. As metabolism increases, ATP use goes up and adenosine is given off by the cardiac myocytes. Adenosine is a direct coronary vasodilator. We often give adenosine for cardiac stress tests because it causes vasodilation of the coronary arteries. As adenosine dilates coronary arteries, it increases the amount of cardiac output that goes to the heart. The amount of neural input to the coronary arteries is very minimal. The cerebral circulation is responsible for delivering blood flow to the brain. The brain is one of the least tolerant parts of the body to ischemia. Therefore, the cardiac output to the brain has to remain constant. The cerebral circulation is supplied by the internal carotid and the vertebral arteries. Through the circle of Willis, there are numerous arterial-to-arterial anastomoses. The reason for these AA anastomoses are to allow constant blood flow throughout the entire brain, especially in the face of possible stroke. The brain receives approximately 14% of the cardiac output. And it's important to remember that 3 to 4 minutes of hypoxia and ischemia may lead to irreversible brain damage. In the cerebral circulation, it's decreased pH in the cerebrospinal fluid from hypoxia or hypercapnia that causes vasodilation. This is a CT angiogram reconstruction that shows the internal carotids leading up to the skull and giving off the circle of Willis. And this is another CT angiogram reconstruction of the circle of Willis. On the left side of the picture, on the right, you can see a saccular aneurysm. This ends our section on cardiac cell electrophysiology. In the next section, we'll be talking about different types of control of the cardiac system.